I'd like to begin with a story from my former life working in a children's mental health agency. At the agency, we kept track of parental employment and sources of income as part of our general assessment information. In 1998, we noticed some incredible year-over-year jumps in this category. First, we noticed that referrals increased by 42% for children from single-parent families on social assistance. Not surprising, given that social welfare rates had been cut by 23% in 1996. But more significant to you, we also noticed a 37% increase in referrals for children from families where there was a parent employed in healthcare. Now, we had always had a lot of children with a parent, most often a mother, who worked in healthcare, usually about 12% of our referrals. So this 37% was not just a jump of 4 or 5 families, it was a tidal wave. In 2001, the last year of my work in that field, we were still noticing a sharp upward trend in this group. The only other time we had seen this kind of pattern was usually short-lived, like when a local factory closed. Now, you've got to be careful about jumping to conclusions with these kinds of data. But if we look more closely at one case history, I think some things will become clear. A teenage girl was referred when amphetamines had been discovered in her school locker. Her mother was a nurse who worked erratic but frequent 12-hour shifts in the day surgery recovery room at the local hospital. She was working at least full-time hours, but on a part-time casual basis. Her name had been at the top of some kind of list to go full-time, but the hospital had recently announced that they were putting a freeze on permanent hires right at that time. And that news was pretty devastating to the family. The father worked for Bell and had recently been shifted from employment status to self-employed status due to Bell's restructuring. And in the process, he had lost his benefits. The family had 2 younger children. One was a young boy with Down syndrome. Dad's health benefits had covered some of the boy's physio and speech therapy costs. The loss of these benefits made things much more difficult. Mom had picked up some extra hospital shifts in order to pay for these services, but the work at the hospital had also intensified. The day surgery unit was busier than ever as more procedures were provided on that basis. Further, Mom was finding that some of the procedures left patients needing more attention than previously. Mom was experiencing quite profound sleep disturbance. She couldn't watch the news anymore because she would find herself getting too upset. Her interest in sex and other pleasures had bottomed out, and she was feeling disconnected from people. Her caffeine consumption had increased, and she'd started smoking again to get through her days. She was also gaining weight. Indeed, she was experiencing many familiar symptoms of depression. My client, the teenage daughter, had been helping her family by picking up a share of the care and housework with particular responsibility for her 2 younger siblings. But the extra burden got to her. She, like her mother, became depressed. The amphetamines, cheap and widely available at her school, had become her self-medication regime. In this story, the interplay of circumstances suggests relationships between chronically caregiving, mental health, and gender that research bears out. What do we know about healthcare workers and their mental health? The research we have suggests that healthcare workers are particularly vulnerable. For example, a survey of nurses conducted by StatsCan and CIHI found rates of depression that are nearly double those of the general population, and that nurses working shifts or nights had the worst mental health. We also know that most healthcare workers are women, and being a woman makes a difference. As Catherine Boydell has shown, there is an expectation that women are the primary unpaid caregivers in households, families, and communities, whether or not they also have paid jobs. And women still do the bulk of the domestic work. This means that variable schedules in paid work are a particular problem for women. It also means that women frequently do a double or even triple load. They do paid work, they do unpaid care and domestic work, and they do what I've always found to be the most difficult part, the work involved in arranging and juggling it all. We know that healthcare settings do not escape the racism and sexism so prevalent in our society, and healthcare workers experience the brunt of it in their work with patients and colleagues in ways that can be physically and psychologically violent, and in ways that limit their opportunities, voice, and participation in the workplace. We also know that some healthcare workers are exposed to a situation where they are at risk of secondary trauma. Frontline workers in particular often work with those who have experienced violence or other trauma, and as the research by Cindy Brandon has shown, this kind of work can quite literally get to you. But it's also important to recognize that many healthcare workers receive positive mental health effects from their jobs. Healthcare workers report that they feel they make a difference for people's comfort, recovery, and both their physical and psychosocial adjustment to illness, disease, and long-term disabilities and frailties. However, the health-promoting aspects of their meaningful work is often undermined by policy and structural changes related to the funding and organizations of health services, as well as to the organization of the work, as my story from clinical practice suggests. Women in particular suffer because they struggle to make up the care gap, as Donna Bain's research on social work has shown. Women workers put in more unpaid hours in their paid jobs than men do, and they suffer increased stress as a result. When we put today's workshop together, we wanted to bring those with an interest and concern for mental health of healthcare workers together. We wanted to review some of the research that tells why healthcare workers are so susceptible to and are increasingly experiencing mental health problems. We wanted to discuss what can be done to improve and promote healthcare workers' mental health, and why this is or isn't happening in healthcare settings. We also wanted to explore these issues with a smaller group so that we could discuss them. We hope to share not just research today, but frustrations and constraints, as well as possibilities and perhaps optimism. Many people asked to attend this workshop, but we could only accommodate this many in this way. We've been both gratified and dismayed that this workshop has attracted the interest of such a large number of people, but it does tell us this topic is very worth pursuing. Today, I'm delighted to welcome our speakers, most of whom will be with us all day, participating actively in our discussions. Although they'll be introduced in more detail later, I take this opportunity to extend thanks and welcome to Linda Silas from the Canadian Federation of Nurses Union, Patty Boucher, who will join us shortly from the Health and Safety Association of Government Services, and Katha Forche from CAW, which represents 20,000 healthcare workers in Ontario. I'm also delighted to welcome our distinguished researchers, including our keynote speaker, Dr. Karen Messing, Tamara Daly, Jacqueline Chouinard from York University, Ben Amick from the Institute for Work and Health, and Margaret Denton from McMaster University. I ask you to attend closely to the presentations and the remarks in order to notice common themes and differences too. Our speakers draw upon a wide range of disciplines and experience, including social epidemiology, sociology, nursing, ergonomics, long-term care work, consulting, union work, and interdisciplinary health policy studies. Like me, quite a number of our presenters have worked in the front lines or management of healthcare services. Our different backgrounds provide different lenses on the mental health of healthcare workers, and I, for one, look forward to acquiring a wider view after sharing our perspectives today. Thank you. Now, if I could ask our first panel of speakers to come forward, the research group. I'm happy to introduce Margaret Denton, who is the Director of Gerontological Studies and Professor of Gerontology and Sociology at McMaster University. Her areas of research expertise include women's health, health services research on home health care, and age inequality. She's held numerous research grants, and most of you might be familiar with her many publications. Margaret, it's a delight to welcome you here today.